recording this session. If anybody wishes if anyone does not want to consent to this recording, please come on mic and state that. Otherwise, we'll just continue with the recording. We did ensure that last week's session has been uploaded to YouTube and is available now. I don't know if you'll see, there was actually a link to it in the chat a moment ago. Thank you, Lorian. I think that's what happened when you provided it to Brittany, right? In the chat? Yeah, so that was kind of cool. All right. So we're going to pick up where we left off last week regarding the 2025 directed payment discussion. And I want to follow up on a few things based on our conversation last week. So let me share screen here. I'm just going to minimize the comments because we don't really need those at the moment. That's where I was putting in some of my notes. One of the things that we discussed last week that we need to revisit here is about same day, next day, and whether the services were delivered by a mobile crisis team, and if those counted for achievement of an encounter, if you will, for same day, next day. And that discussion was really about the fact that mobile crisis services were paid out of fee-for-service, not paid under managed care. And would they qualify? Have they been qualifying? Should they have been qualifying for the same day, next day, and timely access achievements? So we took a deep dive with some internal staff with Medicaid data analytics and shared that discussion with some of the BMHS folks in two different settings this past week. And we are continuing to research. Data analytics is going to pull whether or not the crisis services were counting, if you will. I did pull the regulations around it, and because the crisis services are paid for in fee-for-service, and the cost of those are not incorporated into the rate that we use with the managed care organizations, they should not be included in any kinds of credits towards the directed payment. So the actual delivery of the service should not result in a directed payment because the underlying rates we're paying under managed care do not include mobile crisis services. So now the question we have to deal with is, well, to what degree were we doing it? And that's why I've asked data analytics to actually find out, is it all 10 CMHCs that we were counting those services for as part of that same day, next day, and to find out how that really could have sort of, from a mechanical perspective, happened because the managed care organizations don't get access to the to the fee-for-services transactions until there's I think it's every 2 weeks we give them the data, because it doesn't go through their billing system, right? So they don't see it. It goes through ours. So we need to figure out, what was the magnitude? Was it widespread? How did we actually do that? And then we need to also figure out, where do we go from here? So if it was right, so basically what I'm sharing with you is, if it was widespread that it was happening, then does the department need to take a moment to say, well, maybe we should just bring them all back in to managed care, and then it is we've sort of resolve the situation going forward? Do we keep them in functional support services and go back to the centers and say, you can't use your mobile crisis team for credit on the same day, next day? So those are all brand new, but I didn't want to leave any of you hanging as we were surfacing that discussion last week. So we will have to get back to you on that. Now, the difference is for that timely access to the services, the new directed payment that we're talking about. If that conversation, which is where we were at here last week under mobile crisis team engagement, if it's the mobile crisis team that is saying, would you like to receive ongoing community mental health services? That's fine to be used as the starting point of the clock for the timely access directed payment, because when that person actually gets the intake, the directed payment is on the intake, and the intake is part of managed care covered services. So I'll pause there to see if anybody has a question specifically about that, because it's a little bit of a nuance. That service is in managed care. The mobile crisis isn't. Kelly?
Diana, I just want to make sure I understand what you're saying really in the last sentence is, in other words, the request for application can be initiated by mobile crisis?
Yes.
Thank you.
Okay. So I don't want folks to think that we have to readdress the part of this when right here when we were saying what was appropriate, when it's appropriate for the responding team to make that question about do they want to apply for services. So we don't need to revisit that. But in pursuing some of this discussion over the past week, I've also been in meetings with our Unite Us vendor, the work group that Brian Harvey leads for mobile crisis services, well, for the crisis services period. And we were talking about the referrals that the rapid response access point may make to individuals who are not in need of an immediate crisis service, who the access point does say, would you like to, we'd recommend you start trying to receive services from a community mental health center. They're not a current client for the community mental health center, and the rapid response essentially makes a referral. So when we complete our implementation of the closed loop referral solution, the New Hampshire Care Connections Network, for what we will be doing is developing a standardized workflow for the rapid response access point to be able to essentially create that referral in that solution. And so this is where that crisis system discussion earlier this week ties into our follow-up here, because we talked about the crisis teams responding, but we didn't talk about the access point. So I shared with Brian, and I'm not sure if he's on here right now. He was hoping to join today. I'm not sure if he's here. Yeah, I don't see him yet. So what I was sharing with Brian is your folks' insights from last week, that if for like the hospital DRF request for an intake appointment, your recommendation is that we are not counting that as the first contact, but a referral. So I suspect that you all share that same position for if it's the rapid response team that is making that referral. It's still a referral. It should not count as first contact because you have not heard from the individual or their guardian that they want services. Is that a fair bet? Am I right on that front?
I think that's right. That's, I think, the definition we came up with for a request.
Okay. I just wanted to make sure we were having this discussion here just to ensure that you didn't view that as something different. The one thing that we may be looking at as part of our work for New Hampshire Care Connections is potentially creating essentially a care team that is comprised of all 10 CMHCs and the access point as a mobile crisis care team from the perspective of consent and business associates agreements, et cetera. So it's just sort of saying it's all one team. You're all members of this one team for, mobile crisis services. We are not there yet, but at some point, if we do that, then we might need to rethink the access point as a member of your team that is obtaining the individual's request to apply for services. So for right now, I think it's just, we're going to handle it just like the New Hampshire Hospital DRFs. Carolyn, does that make sense to you? You good with that? Okay. All right. So we've taken care of that piece of it. All right. Just want to unhighlight that so I know that we've done that. All right, on the community reentry program, we were finishing this off last week. And Carolyn, I don't know if you've had a chance to review where we landed on here, because again, this ties into that sort of long the email discussion that we had that included Dr. Burnett's feedback here. So we had, Dr. Burnett had surfaced the question about the 99-200 series, because I know last week we landed on the 3 codes that we would want to use for that secondary service, the post-release service, being 99-205 or 90791 or 90792. And Mary appropriately surfaced that 99-205 is for the most complex cases, and maybe it wouldn't be needed. Maybe it would be a 202 or 203 or 204. I had believed that in the instances of the intake being completed without the prescriber or the physician level, right? 90791 or 90792 would represent just that piece of the intake, but 99205 would be like if the prescriber was available on the same day, because of the requirements for billing of 99-200 series, the underlying services that might be provided by different members of your team towards that evaluation and management service that would be provided by the prescriber, it all has to get billed under the 99-205. And I felt like that was an appropriate use of that code. But we wanted to come back to you folks to see if you did envision at all that you would use 99-202, 3, or 4. We just want to make sure it wasn't an oversight, basically.
I can't speak to any other center, but for an intake and for a community reentry intake for a new client, not established, we would be either doing the intake or the 99205. It has to be the intake itself by the medical practitioner for us has to be so comprehensive. And the time that it takes, it would rise to a 99205.
Seacoast would agree with that. I do have a question about the 90792. That's basically a diagnostic evaluation with med services.
Right.
So and that needs to be performed also by a physician. So I guess I'm wondering why we would include that and the E&M codes. Do other centers, I know
right,
we don't
yes.
use that in general, but do other centers use the diagnostic evaluation with medication services or medical services as their intake?
So I saw a couple of heads shaking no. Did we want to remove 90792? Is there any center that would use 90792?
I don't know off the top of my head, so I hate to say remove it. Also, not having so many codes if I don't have to. So.
Okay. Well, let me share that, that's a good point, Maggie. Let me share this. So 90791 and 90792 were also identified in collaboration with the centers back when we first started the timely prescriber directed payment. So these three codes were also used back then to mark the delivery of the intake, as one of these three codes would represent that the intake had happened. And then we would look for um, uh, if it was 90791 or 90792, we would look for the 99205 to happen within 30 days of that intake. If it was the 99205 that was done, and we did not see a 90791 or a 90792, it would be counted as it happened the same day of the intake. So we wouldn't look for a second follow-up date within 30 days. We would know the intake happened and they've got their prescriber service all in one day. So that's how we were using it before. So I think at some point, folks thought it was good to have 90792 there.
It certainly doesn't hurt, Diana. It is an intake eval with Med Services. She explains, but if somebody did bill it and it got counted, it would be appropriate. If
Okay.
somebody doesn't bill it, it's no harm, no foul.
Yeah, that's
Great.
true. I mean, if somebody is using it, then leaving it in, or
Great. Okay. That's great. I'm glad.
Like, can I
So-
ask a question?
Sure. Oh, yes, Maggie.
Has
Mary,
anybody
yes.
has anybody actually looked to confirm that with a prison reentry patient who comes to you that you're actually using 99205? I mean, it has to be a super high complexity to build that, and I just want to make sure you don't. There's no harm along this line of there's no harm in having codes that are open. There's no harm in having a 99204 and 99203 open, and to have it count. I just, it's possible that somebody could come and be quite stable and that it just doesn't quite pass muster to be 99205, and I don't want that to not count for you. So that's why I suggested having the full array of 99201 through 5. So I just, because there's a high incentive payment for this, I think it's better to have the broader options of appropriate codes than a really narrow set of options.
Well, using the logic of the 90792, you're right, Mary. It wouldn't hurt if somebody did use them. Counting them would be the appropriate thing to do. So it's the same code series, it's the same evaluation management. If they did it for that purpose, then they're gonna come back after the fact and say, hey, we did a 99204 and we would like it to be counted.
and for the sake of inclusion, if the patient had been seen by a like prescriber within the agency within the last 3 years, then they wouldn't be considered a new patient. They would be considered an established patient, even if there was a break in their treatment. So you would need to include the 201s or the 211, 212, 213, 14, and 15. Excuse me.
I agree.
To capture people that we can't consider new patients.
Yeah, I was going to ask about that, so I'm glad you brought it up, and that makes complete sense.
Nancy, let me pause for a second. So now you're talking about the 210 series, right? The 99 210
Yes.
series, right?
Yep.
Okay. And you wouldn't be able to consider them a new patient if you'd ever seen them before, or
Within
is there
3 years? It's within 3 years of the encounter that you would have to look back to see whether or not they had been seen by a like prescriber or, a like provider within your facility. And because if it's been less than 3 years, even if it's not the person or, the prescriber that is evaluating them, they would still be considered an established patient, at least under Medicare rules.
okay? Even if they had been discharged as a
Yes.
patient. Okay.
Yep. Yeah. Even if there was a break in treatment or they hadn't been seen in 2 years and 364 days.
Well, way to go, Mary. All right, is everyone good with that? I'm seeing a lot of shaking heads. Yes, okay.
Yes.
Go team. All right, so we have handled that piece of it. There we go. Just want to note that that's where we stopped on that front. Okay. And that's just some cheat sheet notes that I had there for that. So I will get back to you on the crisis services, the mobile crisis teams, as it would impact the same day, next day, and follow-up services. Just out of curiosity, for the weekly follow-up, has any centers been using the mobile crisis team for that weekly follow-up service until the person could onboard to a clinical team? Sounds like no one uses
Can you
the,
ask it again?
does any CMHC use the mobile crisis team to provide the follow-up weekly service that's part of the same day, next day, and follow-up? So there's the same day, next day event, and then there's weekly follow-up. And that's what I was asking. Are we using the mobile crisis teams to provide the follow-up, the weekly follow-ups pending onboarding to a clinical team?
I'm not sure if we are, but I think it certainly is possible if they're a new patient and they haven't had an appointment yet, their intake, or even if they've had their intake and they reconnect with the rapid response team, that the rapid response team would follow up because they're not really going to distinguish from the contractual requirements of doing follow-up and stabilization for people who actually are probably higher risk since they're discharged. But I'll get back to you. I'm interested if anybody else does that.
Right, right.
I can't say it with 100% clarity, but I'm pretty sure we use crisis stabilization the whole time MCRT people are doing follow-up with people, because that's just how we were trained and did it.
But we're not talking about after a mobile crisis deployment, right? We're talking about after a non-mobile crisis intake. Is that correct?
We're talking about after a person was discharged from a DRF.
Yeah, we're not currently using our mobile crisis team for that.
Okay.
Nor are we.
And
Yeah, Greater Nashua is
Maggie, you just said that Lakes is not?
No, we have our liaison and we have a different track for the person
Okay.
coming out of the DRF. But I thought that Manchester might have been, but I can't remember. But I thought we were in one of these meetings and someone said they use the mobile crisis team for that. But I could be wrong. But
And,
Manchester's not on.
And Nashua generally uses what we call office-based ES clinicians. So they're not clinicians assigned to mobile crisis when they're seeing office-based ES clinicians if we can't get them in for an intake in other ways.
Okay, so Cynthia, then that means they're not billing the mobile crisis.
Right, they would not be billing mobile crisis.
Code
They'd be billing
configuration. So in
either.
that case,
Yep.
That's fine, because that would be covered under managed care, so that would not
Right.
be a concern.
Exactly.
Okay. And CLM, you're not doing it. Okay, so I was just trying to get a sense of that. There's this nuance that intersects with the CCBHC versus the CMHC. So for the CCBHCs, non-ARPA compliant mobile crisis services are going to be in managed care because it's part of the PPS3 rate we will pay. The ARPA compliant mobile crisis services were going to stay out in fee-for-service. And we've gone sort of back and forth on that ARPA compliant. Is it in managed care? Is it out of managed care for the CCBHCs? When the department finishes reviewing that particular issue of is our mobile crisis going to stay in fee for service, or are they going to move into managed care? Depending on what that answer is, may affect CMHCs that are not CCBHCs differently than those that are CCBHCs. That's part of the complexity of what we need to sort of really consider. We've had mobile crisis services going now statewide for over 2 years. And if we made a change to just bring it all back into managed care, it wouldn't be before, I don't know that we'd be able to do it in time for like January 1st. So we're going to try to figure out, and again, stay tuned. I'm hoping to be able to bring some conclusion to this for next week, because as we all know, we submitted the directed payment plan for SFY 2025 to start effective September 1st. I did not receive CMH's approval yet, but I also have no more questions from CMS, and it's been over a month that we haven't had any more questions from them. So I'm hoping it's coming soon. And I apologize for the delay. As you all can see, jointly, collectively, we're moving a lot of change at once, and it's getting us a little bogged down in places. So, and Carolyn, thank you. Brian's not able to attend today. Okay. So I think for now, unless anybody has any other questions on the directed payment piece, we can move on. Okay, great. Let's move on to a little bit of an update on the supportive housing front, the 1915I implementation. I know that I've shared with you that CMS approved our coding change that we needed for the services that would be covered under the 1915I. So we've crossed that hurdle. Internally, we have developed a provider billing manual associated with the supportive housing service 1915I. So even though if any of you on board as that kind of provider type, you would have your CMHC provider billing, we've created a separate one for supportive housing, because a CMHC could be a provider, a doorway could be a provider, et cetera, et cetera. So we needed to create a uniform one. I think we're in the final editing stages of that. We're reviewing what we've drafted with the Medicaid team, and hopefully we'll have that ready for release soon. Jeff Atwood, is there anything else you'd like to share for an update on the provider billing manual front?
No, just that I've gotten feedback on it, and we're filling in some gaps and making some updates as we go. You kind of get tunnel vision when you're working on things. So once you send it around for comment, you get some feedback on things you wouldn't have noticed. So we're cleaning some of that up, and it should be ready pretty soon.
Okay, so I'm guessing the centers would love to get a preview of it to see if perhaps we've missed any questions. And I know we had some sessions specific to sort of surfacing what their questions were, right, Jeff? In the past, we've already had those.
Pretty early on. So,
right.
Yeah.
So we can. Would you folks like to see it still in the draft mode before we finalize it? Kelly's like, yes.
Okay.
Yes. So let's circulate that. Just make sure we have the draft watermark on it and everything. And we'll get that back from folks. Hopefully, Jeff, when do you think you can send it out to them, or when do you think you'll be done the feedback with Katrina?
Hoping by mid next week.
Okay. So if we send it out, do you think we could get your feedback in a week, or do you need 2 weeks? The sooner would be the better, obviously, because we wanted to start this in July.
A week should be fine.
Okay, great. Thank you. So that's on our to-do list. And then on the prior authorization forms or the service authorization forms. We've developed that. Lorian, have we already sort of discussed that in one of these sessions here where we've sort of run them through what we were looking like, the pre-population of the codes, et cetera?
I'd have to look back at my notes. Do you mean have we showed the form?
Right, right. I feel like we
I'm not,
might have.
I'm not sure.
Okay, maybe we just discussed it. Okay, so we don't necessarily have to show it this time, but we can share it with you next week. If folks want, we'll add that to there just in case you have any questions about that. Lorian, can you give us an update on the provider enrollment so far among the CMHCs?
There are still no providers fully enrolled. It looks like some applications have been started and not completed. There are a couple that are in process.
So are any of the centers having any challenges with Conduent or the department's resources about completing the provider enrollment process?
Diana, our holdup, just so you know, is nothing to do with anything like that on your end. It was all about our board and the information needed from them and needing to wait for a board meeting to have that conversation, which for us happened this week. So we're hoping ours will get completed next week.
Great. Anyone else need assistance? I mean, if we can
Yeah, I
help.
think we were just waiting for
prod.
this additional guidance to have full insight into what we were stepping into and what the process was. It was hard to enroll. We started enrollment as well, but it's hard to complete that when we don't even really know what we're stepping through.
Okay. All right.
Yeah, that's exactly where we are. I think once we see that, then we can have a discussion and talk with our board about whether it's something we're going to pursue or not.
Okay, so if we have the draft provider manual, that will help provide some insight. Would you like to see the draft authorization form as well? Because that provides some information. And then Jeff and Lorian, don't we have some draft guidance that we've been developing as well?
I think we met
Oh,
with
it's the
Greg
application,
about
yeah.
that. Yeah, the application has been completed.
Yeah,
And
the application, the notice of decision drafts.
that's right.
Okay, all right. Would you folks like to see all the drafts? Will that
Yes,
help you?
please.
Absolutely.
Okay, all right.
Yes.
Let's do that. Let's see, is Melissa on with us this morning? Melissa Hatfield. Let me see, just in case she wants to jump in and share anything from her bureau.
I don't think she's in.
Yeah, okay, she's not here. Anything else you want to share, Lorian or Jeff, about the supportive housing?
No, I think that's
Nothing.
it.
Yeah, nothing at this time.
Okay. We did send a message to CMS yesterday because we want to be sure that our interpretation of the conflict-free case management as we would apply it, as we planned to apply it for those people who already have targeted case management from another benefit under the state plan, how that would intersect with the conflict-free requirements in the 1915I. Specifically, the 1915I includes the type of case management where the case management organization is prohibited from being the provider of the services and the underlying care plan. We are interpreting that as if the person is getting their case management services under the 1915I, then that case management organization could not provide the underlying supportive housing services. But for those individuals who are getting case management elsewhere, such as most of your clients do, they get them from the centers, your case management services do allow your organizations to be the provider of underlying services. It is that way also for the DD system with the area agencies. They must be separate for those individuals who are getting their case management out of the CFI system. They cannot be the ones that are providing the underlying services. So we sent an email yesterday asking for them to confirm if this would be consistent, if our interpretation would be consistent with the parameters of the 1915I. We will get that answer before we finalize the drafts, but we can still release the drafts to you for now, because again, that will help you have your conversations with your boards. I just really wanted to be transparent about making sure we know that where that conflict-free element hits across multiple benefit packages. We did confirm with them several months ago that it would be perfectly fine for individuals to continue to receive their case management in the other system. We just didn't have in our notes that we took it down to the level of could they also be the same providers. So that's the one question we want to go back. We've gone back to them with. I think that's all we have for updates on supportive housing. The work that we're doing with the Unite Us team and the mobile crisis work group with Brian, as many of you folks know, because I've seen you in those meetings, we are taking the priorities associated with use of the mobile crisis teams, those case scenarios, and those are what we're teeing up first for Unite Us to engage with the centers on. The receipt of referrals from other agencies, right? Once you learn how to do the referrals and receive the referrals from the rapid response point, access point, then that will naturally dovetail in your ability to use the platform to receive them from like the doorways or from 211, et cetera. So if you are using staff that are really specifically in your crisis system space, if you will, within your teams, just bear in mind that at some point you'll want to think about it in that larger level of receiving referrals anywhere. Now, the Unite Us team will probably set up special sessions for that, but if you want to maximize use of the platform sooner rather than later, and you want to seed some of those meetings with people from like your admissions team, your front office, so that they can get acclimated sooner rather than later, that's perfectly fine too. So I just wanted to put that plug in for you. Okay, I think the next service that we are going to move in to discuss is the peer support service, adding that. We'll start there for next week when we reconvene. Does anyone have a concern about taking on the peer support service discussion next week? This is so that we can inform what we will put into the state plan amendment. So when you decide who to bring to this table for next week, think about that. We'll bring forward a draft of that language, and then we'll want your feedback and to talk about it a little bit more. The codes that we'll be using for it are the H0038 and H0038HQ, so individual and group. So I don't know if you're going to want mostly your clinical teams here next week or your billing teams, but I wanted to make sure I gave you those codes. It'll be the same price points that we use in the SUD system. So if you just go into the regular fee schedule, you'll see those prices. Lorian or Jeff, if you feel like it on the side, you want to throw those prices in the chat, that's fine. It's H0038 and H0038HQ. But they're published, you can see those. So let's tee that up for next week's discussion. I'm also finishing, I had planned to finish the removal of the prior authorization requirement for the functional support services. I said I would try to get that draft guidance document out to you folks, but I have not yet been able to catch up with Carolyn. Our schedules have both been very busy, and I want to make sure she gets to provide her feedback first before I send the draft to you folks. So it is coming. I'm trying to make it a fairly short document, probably just 2 pages, because we would be looking at issuing the guidance essentially to bypass what our current written rule states. We need to put some background information, because that sort of serves as laying the foundation for why we will issue guidance that essentially is contrary to our administrative rule. So we that's part of what we want to make sure we do well. Does anybody have, I know that you folks have gotten a lot of emails in the past 2 weeks about it, but what we are really just changing is removing the requirement for the prior authorization if you need to exceed 10 units per day. And that is the bundle of the functional support services. You can still bundle those. We have not envisioned that we would remove them. We have talked about that internally, so we would not remove the ability to bundle those codes together. The biggest concern that I think that the centers will need to think about is making sure your clinical documentation is significant enough to justify the quantities that you plan to deliver. You just don't have to do it a second time and justify it in a prior authorization request. You don't have to submit the prior authorization request. And again, that was effective for September 1st. So you're free to change whatever you need to change internally, so you don't have to initiate that prior authorization request. Your billing, if you're still billing bundled, it'll still go through as a bundled, because we're not changing that. Any questions on that front?
And when do you anticipate the written documentation being complete? I'm sorry if I missed that.
No, I think that we can get it to you for, Carolyn, what's your capacity early this week if I send it to you today? Are you straight out next week? Like, I don't know if you're on a trip or something.
No, I'm not on a trip. We should be able to look at it.
Okay, great.
Right, because I
For
feel,
next week,
you know,
yeah.
we need the written documentation, since this rules carry the weight of law. So I would want that in writing.
Right. So we will try to finish that, and I don't think we've received any prior authorization requests to exceed the 10 recently. Lorian, have we received any recently?
Yeah, a month or 2 ago, and some of the date requests did go beyond September 1st, but I just put in the request ending August 31st.
Okay. All right, because we knew the system would process after that.
Right.
So, all right. Does anybody, I don't think any of you have any immediate need for exceeding. When we did an analysis of utilization, there really was a small percentage that needed to go over 10 units per day on a predictable basis. So, all right. I don't have anything else for today session. Does anybody need to surface anything here before we sign off and you get 10, 13 minutes back into your schedule?
Hearing none.
All right, folks, have a good week. Thank you so much for your time today.
Thanks, Diana.
Thanks, Diana.
Thank
Thanks.
you.
Bye.
Thanks, Diana.
A good day.